I'm going to read these statements that are out there on YouTube from medical professionals or medical organizations that I don't think you're going to entirely agree with. But I want to get your reaction to them as someone who's researched these areas perhaps better than anyone out there right now in the medical industry, and the volume of kind of information that you've produced based on data. I want to tell me if these statements correlate with the best information out there. Okay, so here is one for you. I tell my patients, you could race Usain Bolt down the 100 meters straight. You just couldn't do the 400 meters because you started going round, and that's when your knee might start giving out. I presume they mean going around the track. So turning, not exactly sharply around a 400 meter track, but what do you make when you hear of that?
So assuming that's a reference to non-surgical management?
Yes. Yeah, this is people that haven't had surgery and attempting to return to the 400 meters.
Yeah, wow. Yeah. So that's actually fairly common, not known as exact words, but that's in relation to people saying, if you want to run in a straight line, as I was told, if you want to run in a straight line, you don't need surgery. But if you ever want to change direction or turn a corner or anything ever again, yeah. So as I said, the best evidence we have is no difference in return to sport rates, whether you have surgery or not.
Yep.
And no strong evidence. So the most recent review of the literature couldn't find evidence to support the fact that your knee's at greater risk of further injury if you don't have surgery. So that may be reflecting a small portion of people who don't achieve that function, and maybe it's 40% of people if you're not considering a bracing protocol. But they then should go on to have surgery. So that's not representative of the 50% or more of people that will have a successful function and be able to play sport and do the things that they want to do. But anyway, the short answer is I would definitely disagree with that. And it isn't also acknowledging that people can have poor outcomes after surgery and may have difficulty running 400 metres if they have a surgical route as well. So it's not sort of acknowledging that outcomes are similar on average if you have surgery or initial rehab.
You won't be surprised to hear that was from a surgeon.
Mm-hmm.
Our next statement, this is a bit of a long one, so bear with me, but I feel like it's worth reading in full. Okay. The hard thing with non-operative management, particularly in our young athletes, is you have to tell them there's things they can't do. They can't play soccer. They can't play football. The twisting sport side to side that is something they're no longer able to do. Every time they do those twisting type motions, there's a chance of more damage in their knee, and some of that damage is irreparable that we don't want to start. We try to maximize quads and hamstring strength, but no matter how strong we get them, it's not going to make up for that lack of ligament.
Mm-hmm. Yeah, so I think I've touched on this, but we will be publishing a systematic review next year comparing return to sport rates between treatment strategies that shows no difference in return to sport rates. But interestingly, that no difference is despite the fact that most study designs have actually either told people that aren't having surgery, you shouldn't return to sport. And even with that advice and people that have surgery being encouraged, the same proportions go on to return to sport. Even with that advice, or even with study designs that select people, or they say you don't have an intention to go back to sport, then you should have rehab only. And if you want to return to sport or you have the desire, you should have surgery. Even in those designs, similar people often go on to return to sport. So that is, it's not based on the evidence we have available at the moment that if you want to return to sport, you should have surgery, and it's not safe to do so if you don't have surgery.
You're making it sound like there might actually be some risks to surgery, but we're not here to say against surgery. But if you're giving people essentially that psychological disadvantage of telling them what they're doing isn't right, and they're still achieving at the same level of those who have had surgery, and then there clearly is some stuff that's happening in surgery that's also impacting them in a detrimental way. So that's
that's interesting, isn't it? So if we had designs where people were given the exact same advice, no matter which treatment they had, surgery or non-surgery, they were equally encouraged to return to sport. They were given the equal amount of support. They weren't told, it's not safe to return. They weren't told these things, which they are being told at the moment in the majority of cases. then I wonder what we'd see in terms of return to sport between those treatment groups if it was less biased in terms of the information and the outlook that's often still given by clinicians.
Yeah, and I think we'd all love, if we were going through that pathway ourselves, to have that clarity of mind. Like, I know I've been back playing now, and I've played probably 10 plus competitive games since my injury, and I still have to psych myself up. I still have to remind myself. There was a guy I played football with who he'd actually been out playing in Scandinavia and had a knee injury and came back, and he was playing the same team as me, and he played 12 seasons without having his ACL reconstructed, and was probably the best and the most agile winger on our team, and was doing it. And I always look to him as that reminder of, like, you can do this. He did it. That's the best evidence you can see as a human being doing it. But not everyone has that kind of that clear and kind of tangible reminder they can lean on those moments of doubt. Next one is this one probably goes as far opposed to you from a perspective as you get. Our statement 3 is people who need. So this is considering people who need construction and don't. People who need reconstruction are definitely young athletes who are playing cutting and pivoting sports. That is a no-brainer. They're going to twist that knee again without an ACL, and they're damaging cartilage and tearing meniscus, and sometimes that process is irreversible. And the bit I love about this one is this is a video, and the professional in this video is holding a artificial knee and doing the actions of the knee twisting, and it's quite confronting. It took me a while to shake this one off.
Wow. So the first thing I'll address there is the age, right? Because you're right. We found this in our recent study, is that this common belief, and it exists amongst physios as well, is that if you're young and wanting to return to sport, surgery is the best option. But if you're older or have a low activity level, or ideally both, then maybe you can consider rehab. So this age thing, right? So if we look at the evidence, we know that younger people, especially young people that return to sport, that's a risk factor for worse outcomes with surgery. So they're more likely to rupture their graft, which is a big concern. So if you're young and returning to sport and have surgery, you're more likely to have a graft rupture and then poorer outcomes. However, the same evidence doesn't exist suggesting that if you're young and try rehab first, you're at risk of poorer outcomes. There's nothing out there that's found anything along those lines. So why then should we assume, when the only evidence suggests that actually being younger and having surgery can be related to poorer outcomes, why should we assume that only older adults should be having non-surgical management? It doesn't make a lot of sense to me, and it's not based on the evidence at all. And then we've discussed the activity level and return to sport misconception, which is still highly prevalent. And then combined with age, it's just not supported by evidence.
So not a no-brainer.
No.
We laugh about it because we'd probably both be crying if, as people have suffered ACL injuries at a young stage of our careers. It's pretty sad to see. And then final statement 4, and this is more focused on, I guess, when we get into the trenches of the fear-mongering here. Okay. Every time your knee buckles or gives way, you risk doing more harm to the knee, damaging or tearing meniscus, damaging or tearing the articular cartilage, and that can create problems sometimes that we can't fix. I've picked this one because I wanted to focus on that very last bit there, the irreparability of, I'm not sure that's a word, but the irreparability, I'm going to double down on that, of a secondary injury that can occur, right? And that's what really scares people, because they go, if I play about an ACL, I'm going to do something really, as if rupturing your ACL is not a really bad injury. I do something really bad, and there's no way back from that. Because interesting, because what you've told us is that actually it's the surgery and then the rupture of that. There's no way back from that because healing capacity is gone. But I wanted to get your take on this concept that the damage that you could do is irreparable.
Yeah, so I think what this is referring to is, for example, a very severe meniscus injury that doesn't respond very well to surgery, and it, leads them down a path of early onset knee osteoarthritis. So we really want to avoid that in both treatment groups, for the surgical group or the non-surgical group, which is why I said earlier it's so important that people are avoiding multiple episodes of giving way, because that's a sign that surgery is really a good option for you, or activity modification, but you don't want to be causing accumulative damage to the knee.
But
on the other hand,
that's potentially more related to the exposure risk that they're putting themselves in, right, by doing activities prematurely.
Well, not necessarily, because not everyone will go on to have a stable knee.
Yeah.
Right. So it's about trying rehab first and seeing if you're going to have a successful function, which at least 50% do with rehab first. But this may be much higher with this bracing protocol, we suggest, based on what we're finding. But we don't suggest everyone has rehab and then you'll have a successful outcome and no one needs surgery. That's not at all the suggestion. So I would agree that you want to avoid multiple episodes of giving way, definitely, that can cause damage to the meniscus and cartilage. On average, we don't see more damage to the meniscus and cartilage with people doing rehab compared to those doing surgery. So you need to keep in mind that graft rupture, so like in young females who return to soccer after reconstruction, 1 in 3 rupture their ACL graft. In 90% of cases, that's also damaging the meniscus and cartilage.
Yeah. So
this is why it evens out, because there's risks down both treatment strategies. It's not everyone will experience giving way episodes if you have rehab, and ideally you're only experiencing one, and then you're changing your approach and then going on to think, hey, I tried, I'm not obtaining sufficient function despite strength in rehab, so I'm going to now go down the surgical route. The other thing is, the trauma of the surgery itself in relation to OA risk. So things do even out because there's pros and cons down each treatment strategy, but there's research showing that the inflammatory response, so the surgical procedure itself, if performed early after ACL injury, it causes prolonged inflammatory markers that are higher than the non-surgical group, but they're also higher than the group who have surgery later after trying rehab. And they're not just higher in the short term, like for the first 6 months, but they remain higher still 5 years later. And these same inflammatory markers have been associated with osteoarthritis development in the knee. So we don't yet understand what's driving high OA rates in each treatment arm, but it could be that some, undergoing a second trauma to the knee whilst it's still quite aggravated and inflamed, like a second insult to the knee, including drilling into bone, and it's quite invasive, could have a negative impact on these inflammatory markers.
Yep.
As opposed to allowing the knee to calm down before deciding whether to have surgery potentially 3 months down the line, for example.
Yep.
So it's not as black and white, this statement, because I would agree that we don't want to allow someone to have ongoing episodes of instability. But it is painting a picture that it's more dangerous to try rehab only compared to surgery, which isn't the case. And it also doesn't acknowledge the many surgical risks and complications that can occur, and risks at the graft side and graft morbidity, and other negative sides of surgery that aren't equally there if you do have rehabilitation alone. So these are the sorts of things we discuss in this online patient decision aid, because it's not black and white, but people should be informed about the risks of both options so they can weigh out what matters most to them.